There was many traditional ways of calculating the IOL power. Number one was the refractive method, just to obtain preoperative refraction and substitute it in this formula. IOL power equals 18 plus 1.25 times the preoperative refraction in spherical equivalent. So, for example, if a patient has 4 diopters, spherical equivalent, times 1.25, this is 5, plus 18, so the IOL should be plus 23. Somehow accurate method, but nowadays we depend on a lot of machines and equipment to obtain the precise IOL power. Hence, many formulae were developed, starting with the theoretical formulae, which had no data at all, and then the regression formulae that used audited data from pre- and post-op refractions. We'll come to this after a while. I need to discuss first the Royal College guidelines. In short, we need to obtain the axial length and the K readings. The Royal College depends on the axial length to choose the precise formula. So in axial length less than 22 millimeters, use either Haigis or FRCOphth. In the regular axial length between 22 and 26 millimeter, we use the FRCT. This is the most commonly used formula, but maybe slightly more accurate, the Barrett Universal 2 formula. The problem with this formula, it's not published. It's a proprietary formula that depends on certain constants that are not published. It's a software that you need to pay for. So if it's integrated in your machine, in your biometry machine, you can use it, Barrett, the BU2 formula. But the Royal College doesn't advise to transcribe the data to the website or to another machine to obtain the IOL power. Usually, if you transcribe it manually, you'll get a difference, or you have a higher error rate of up to 0.5 up to 1 diopters. Barrett Universal 2 formula is integrated in IOL Master 700, but not the 500. By the way, it's also integrated in the LensStar. So if you have any of these machines, you can use the Barrett Universal 2 formula. In eyes with axial length more than 26 millimeter, use the Haigis or FRCT formula. Usually, it was traditional that FRCOphth is the most accurate for short eyes, for example. But recently, contemporary data from audits proves that Haigis might be superior to FRCOphth, especially if the AC depth, which is one of the variables involved in this formula, is less than 2.5 millimeter. And this is quite common in eyes shorter than 22 millimeter. There are several studies that prove that the median absolute error is much less in Haigis formula. So Haigis is superior in shallow anterior chamber depth, while FRCOphth exacerbates the hyperopic shifts. So more hyperopic shifts happen with FRCOphth in shallower AC depths less than 2.5. This happens because FRCOphth has less tendency to predict the effective lens position, although it uses clever constants. Haigis uses 3 constants to optimize this measurement of this constant. This takes us back to the formulae. As we explained, the refractive formulae and the theoretical formulae, which are now deemed obsolete by the Royal College, like the Binkhorst, like SRK1 and SRK2. Second generation formulae and third generation formulae, the regression formulae, like Holiday 2, SRKT, and FRCOphth. And most recently, we have the AI hybrid, the artificial intelligence hybrid formulae. And the example for this is Kane formula. Kane formula outperforms Haigis and FRCOphth. Kane is here. Kane formula outperforms Haigis and FRCOphth in short eyes, and in fact it's best overall for all axial lenses. So it has outperformed all other formulae. But the problem is the Royal College doesn't advise on Kane formula because these data are derived from studies, from published studies, not derived from validated audit data. So the Royal College advised on integrating the Kane formula results into our NHS audit data so that we can adopt it in the near future. There are screening criteria integrated in the Zeiss IOL 500 and 700 that advises on repeating the biometry or repeating the measurements during the same sitting. This is different from the criteria that we'll be discussing shortly regarding repeating the biometry if the surgery was not performed directly after obtaining these data. So, if an eye has an axial length of less than 22 or more than 25, repeat the biometry at once. Perform 2 biometries. If the average corneal power is less than 40 or more than 47 diopters. By the way, K average is not delta K. Delta K is a measure of the astigmatism, not only corneal astigmatism, anterior corneal astigmatism. So delta K is not accurate in post-LASIK cases, for example. K average as well is not accurate after LASIK, but delta K is not involved, is not a variable in the formulae for IOL calculation, while average K is involved in biometry. Now, from the machine, once you perform the IOL 700, for example, it gives you in a red line, in a red writing, please repeat the biometry because axial length is less than 22 millimeter, for example. Or because the IOL power calculated to give emmetropia is different by more than 3 diopters of the average power for the specific lens type. This is something in the machine, in the data, that gives the mean for the emmetropic IOL power calculation. And if there is deviation from this mean, the machine recommends that you repeat the biometry. Number 4, if there is a difference between the fellow eye, if there is a difference in K average by more than 1 diopter, or difference in the axial length by more than 0.3 millimeter, or a metropic IOL bar is more than 1 diopter difference between both eyes. So if you have a calculation that gives a metropia in the right eye of 22 and in the left eye of 24, in this case the machine will advise on repeating the biometry. Now we come to the OptiWave, ORA, OptiWave Refractive Analyzer. This is a machine, an integrated software and hardware attached to the microscope, and the software that gives you an accurate lens calculation, an accurate IOL calculation. So you perform your phacoemulsification, remove any debris, fill the anterior chamber with viscoelastic, make sure the pressure inside the eye is within normal range, and take a biometry measurement by the ORA system, and gives you calculation of the IOL power. This calculation depends upon a biometry, and it's independent of axial length and K readings. It depends solely on aberration, on aberrometry of the eye. As you know, we can obtain the axial length by either ultrasound, the A-scan, either contact or non-contact. And non-contact is preferred because it doesn't give the bias of axial length shortening. As you know, contact A-scan gives axial length shortening by 0.3 to 0.6 millimeter. So the optical biometry is not as accurate as biometry obtained by light, by lens star. This machine, lens star 900, or by this is from Hagerstreit, and it's available in the NHS as well. It's more into refractive work, and the IOL Master, the 500 and the 700. 700 IOL Master is the most developed or advanced machine. It uses swept source OCT light to obtain very accurate axial length measurements. And this is one of the few commercially available swept source OCT scanning that's involved in the IOL Master 700. So we have explained the kinds or the types of formulae and how to obtain the IOL power. Now we come to when to repeat biometry. So this is different from what we discussed earlier from holiday criteria to repeat biometry in the same setting. This is when to repeat the biometry if a patient had a biometry and didn't have the surgery, and then he is coming back after some time for a surgery, when to consider repeating the biometry. If the previous biometry is more than 4 years old, if this patient is undergoing IOL exchange, either for post-operative refractive surprise or because of cloudy IOL, you need to repeat the biometry in both situations. If the patient had previous corneal surgery, PKB, keratoplasty, or progressive corneal disease, if the patient had a major eye operation since last biometry, for example, a patient underwent PPV for full thickness macular hole repair, and he didn't have cataract surgery on the same occasion. So when he comes back for the cataract surgery, and as we discussed earlier, 80% of patients who have PPV for retinal detachment or even full thickness macular hole will need cataract surgery within 1 year from their surgery. In this case, you need to repeat the biometry. Axial length changed due to eye disease. So axial length might change if this patient has high myopia. This is less evident in axial length from 26 to 30, but patients above 30 millimeter are at high risk of changes in axial length. Patients with posterior staphyloma, patients with uveitis, patients who underwent scleral buckling, patients who had retinal detachment. If there is considerable change in measurement system or devices, or if there is change in the type or supplier of the IOL. In fact, these two are of logistic consumption. So if you change the machine or the measuring device in your setting, you need to repeat the measurements. Or if you change the supplier of the IOL, you need to repeat the measurements. Patient safety terminology regarding choice of IOL and choosing the best calculation to get the most optimum results. NHS England set up what was known as National Reporting and Learning System. It has now become the Learn from Patient Safety Events, LFPSA. So you need to report any of these to this system with different thresholds of reporting. So if you have an adverse event or adverse incident, which means that unintentionally you have chosen an IOL that led to post-operative difference of 2 diopters from the aimed at refraction. This was unintentional, but should be studied. Why did this happen? What was the reason for this 2 diopter difference? Near misses. This should be, by the way, this should be reported, especially if there is moderate to severe harm to the patient. Near misses. This is something that didn't happen. So, for example, the IOL was meant to be 20, but you were brought an 18 diopter lens, and you were about to implant, but because of checks, because the surgeon was alert, did not implant this lens. So it wasn't implanted. So this means that no harm and no reporting needed, or no reporting is mandatory, but it's encouraged. And from every 10 near misses, only 1 is usually reported to the LFPSA. A never event is something that should never happen. This is a list on the NHS website, and it's like implanting the lens for the right eye in the left eye, okay, or operating on the wrong eye with resultant implantation of the wrong lens. This is something that should never happen, and it mandatory reported and should be investigated. Unexpected outcome, this is not something to be reported. It's like a refractive surprise. And this is something to be audited, not something to be reported to the patient safety. From this, we can